Good afternoon, morning, evening, whenever you're watching this. Um, this is my coffee break today. I have my water. I know probably not as exciting as coffee, but I figured if my mouth gets dry, it'll be something that will be good. Um, so it's not as dry. Uh, Before I begin, I just want to apologize for those that were in the talk about with my session the other day. It seemed like people were excited when I joined. However, for whatever reason, we were having audio difficulties and no one could hear me speak. And despite multiple attempts of restarting, trying different things, it wasn't successful. But from what I heard, because I could hear you and I could see you, it sounded like there was an excellent conversation, excellent discussion that was going on about pain and symptom management. So I apologize I couldn't participate with you. We're hoping that I can figure out what's wrong with my computer and we can make it work for the next Talk About session next week. Hopefully this week's session was valuable for many of you. I know it was a different change in focus, a different approach to what we've been doing up to this point. We've basically been talking a lot about palliative medicine as a whole and goals of care conversations and kind of the psychosocial realm of patient care. And today, or this last week, we kind of switched gears looking more specifically about the physical piece and the physical symptoms that really can impact a patient's quality of life. I know sometimes it's not as exciting. And maybe it's something that actually you're more passionate or more interested in. We weren't able to get through all the different symptoms that can affect a patient with cancer. That would be forever course, which is why we kind of highlighted just the main ones: pain, nausea, and fatigue. But do realize that there are many different physical things that can really impact a patient's ability to enjoy life and be able to get through their cancer treatments. I just want to do one quick, again, shout out to the reference I mentioned in my email post, which was the evidence-based practice in palliative medicine. And that's, again, not textbooks you have to get. And there are other books that are very similar and do kind of similar things. It's just one that when residents and fellows ask me about something, it's soft bound. You can take it with you, put in your bag. The chapters are broken down by different physical symptoms, more or less. And at the very bottom or the end of each chapter, a huge references as far as what the data is that's out there. So if you really want to do a deeper dive, it's a good place to kind of be able to go and look for it. Another reference that I wanted to put a post out there is the Fast Facts, which is originally came out of Wisconsin. I think it's Wisconsin, School of Wisconsin. However, it got moved over to CAPC and now since has been on its own web server. It also does have an app that you can download on your smartphones. The nice thing about the Fast Facts is you can search by any symptom and it will take you, again, kind of just like the quick, dirty, what is the most clinically relevant information that's available? What are the studies saying? What's the evidence saying? And that's kind of been updated continuously through the years ahead. But that's another good resource if you're looking for something quick and dirty to get. There's a question that you're looking for, and just like the books, they usually will have their references at the bottom of the page, so you can do a deeper dive if you're interested in. During the session, I just wanted to highlight a couple things as I've been looking through the forums and a couple questions that have come up that I've noticed, or at least themes that have come up in those conversations. One being that even though we're focusing a lot about the physical aspect of symptoms, specifically with pain, I do want to echo the idea that pain is multifaceted. And I think it's important that when a person is having pain to realize that there may be different aspects of what that pain really is about. A person can have a lot of emotional pain. They can have a lot of spiritual or existential pain, and that pain is just as real as physical. And making sure you have an assessment to know what type of pain you're dealing with will then better help you, will allow you to be able to make a plan that will address and help the patient kind of counteract it. So if a person who's suffering existentially and they're in a lot of distress, giving them an opioid or pain pill is probably not going to fix the problem. You really need to go to the source of what the problem is and really help them kind of work through the process, which is then you want to use other members of your team to help you do that. Oh, the other piece that was coming up, I noticed in the forums, was this idea of, um, well, why not prepare patients for the future? And I totally agree with that. I think that's a huge part of what we can do in palliative medicine. And really, that's what we do in medicine in general. Is if we can prepare patients for what to expect, it lessens or decreases the amount of distress and emotional angst that physical symptoms bring. A couple examples you see that in medicine is, a person who is pregnant, a lot of their appointments during the pregnancy, yeah, you're doing ultrasounds and you're doing measurements and you're doing checks, but a lot of it is education. It's talking to, the mothers and the fathers, like, this is what's to be expected. I expect you to do this. I expect this to happen. And this is in the realm of normal. And if it's not, then I need you to get or seek assistance. Similarly, in family medicine, pediatrics, we see that with well child visits. A lot of the visits that we make for well visits, yeah, we're doing physical exams, we are checking height and vision, but a lot of it is education. It's talking to the parents, saying, hey, this is your 5-year-old. These are the developmental milestones I expect them to do. If they're not doing this, I need to know. And similarly, I think we need to do a better job with that with patients with a disease like cancer. Um, we have a lot of data. This is something that's nothing new. This is something that's been around for a while, and so we have the information to be able to tell patients, this is what I expect. This is within the realm of normalcy. Oh, it looks like your oncologist is going to start you on chemotherapy X. With chemotherapy X, I expect you to have nausea. That's to be expected. That's normal. And because of that, this is what we're going to do to combat that. Or with this chemotherapy, it's common, I see, for patients to develop neuropathy. So if you start getting tingling, you start getting numbness, I want to know, because that's normal, and I think we need to be able to treat that. I'm going to give you a pain med. I'm going to give you an opioid. I'm going to cause you to be constipated. That is normal. That's to be expected from getting an opioid. I don't want the patient to have to come back to me and say, gosh, I'm constipated now. What's happening? You're much better off being proactive and telling them beforehand and actually prescribing the laxatives and the bowel stimulants to begin with. I think a really great example that I see a lot is this idea of appetite suppression or appetite decrease, anorexia. So all patients with cancer, 100% over time, lose their desire to eat. Their appetite changes. But it's amazing how many people don't realize that. They don't know that. So if we educate and say that, yes, this is to be expected, this is normal, when it starts happening, it lessens the distress. It doesn't make it as scary. And so again, going back on some of the things that like Sandy's talked about in the earlier modules, looking at kind of the whole person and looking at the 4 quadrants of health, you really start to see how, a physical symptoms start to kind of impact emotional and spiritual symptoms, or spiritual health, excuse me. So that all very much goes together. And so anything you can do to prepare patients for that, you're going to be better off. And then my final piece before I go, I apologize if I have to go teach a class, but my final piece I want to mention is don't rely just solely on medical or medications for treatment of symptoms. I think, speaking as a physician, it's really easy for me to say, here's a medication I want you to take. I order med, go pick it up. But there's a lot of things outside of a pill that can help patients. So, exercise is always a great intervention to help with fatigue. Talking and educating about sleep hygiene, mindfulness training for anxiety. So it's not just here's a script, but looking at all your non-pharmacological interventions, which really allows, I think, palliative care to look at like the whole toolbox, look at what all the things we can do to really impact a patient's well-being. So anyway, those are some of the thoughts that I had for this week. Hopefully this was useful for you and is able to at least kind of answer some of the questions you may be having, or at least prompted you to have a little bit more thoughts about symptoms in general. I will be around for this week, and for the new module coming out this week, we're going to continue our discussion about symptoms. Kim, who's one of our clinical nurse specialists, will be kind of meeting Sarah for the first time. You'll see that, but I will still be available for any questions that may pop up on the forums, and then hopefully I can participate in the talk about next week. Thank you so much for participating. We're excited to have you be part of this class, and hopefully by the end of it, you feel a little bit more comfortable about palliative care. Thanks.